So far we discussed about lobar pneumonia, second one broncho, third one is interstitial, pneumonia. Okay, this pneumonia all comes in the acute bacterial infection. Okay, especially this two pneumonia comes in the acute bacterial infection. Infections, right? So this one comes in viral infection mainly or atypical bacteria, mainly viral. Okay, mainly viral. So now we are going to discuss about in Saudi it is not common, but worldwide it is creating a big problem. So it's a chronic inflammatory creating bacteria, mycobacterium tuberculosis. Otherwise I call generally as a mycobacterium. See, we already discussed a lot about this basic principles involved in the mycobacterium and the principles of disease. So now we are going to specifically talk about mycobacterium infecting the lung. Okay, because primarily it infects the lung because it is in the air. Actually, the mycobacterium is in the air because we breathe. If, for example, if you are going to India or any South Asian country, or even nowadays if you go to any Western countries, you may get mycobacterium inside the lung. If you have very good immunity, it will kill the mycobacterium and you will not get the disease. Okay, so getting infected by mycobacterium is different. Getting the disease because of the mycobacterium is different. You understand? So for example, I may be infected by the mycobacterium. Alhamdulillah, I have a good immunity, so I am not getting the disease. Understand? So getting infected is different. Getting the disease is different. Okay. So the most commonest mycobacterium which affects the lung is Mycobacterium tuberculosis. Mycobacterium tuberculosis. There are different types of mycobacterium. One of the most commonest mycobacterium is tuberculosis, which commonly infect the lung, produce pulmonary tuberculosis. Produce pulmonary tuberculosis. Okay. For example, I told in the beginning itself, this infection is so common in some countries, but they don't produce the disease. Okay, so when the person is having less immunity, they will produce the disease, right? Okay, so what are the situation where the person can get less immunity? For example, if he is living in a poor country, okay, or developing country, or living in a war zone country where they don't get proper food, all those stuffs, then they will have. Otherwise, we call it as a low socio-economic countries. Low socio-economic countries due to many reasons. So they don't get proper food, especially the proteins are needed to have a good immunity. So in such countries, it is very common. But in the developed countries, the scenario is little bit different. In the developed countries, the biggest problem is HIV. Developed countries, the biggest problem is HIV. Otherwise, you can call it as a non-Muslim Western countries. Okay, so nowadays even in the Middle East, some countries we don't follow the Sharia, so they all have a the biggest problem in them is HIV. In those individuals, the immunity is very much low, and I will tell you how it affects the tuberculosis, and they will get the disease. So nowadays, it is a problem of developed as well as the developing country, and even the poor countries. Okay, it's a general problem. This pulmonary tuberculosis. Okay. So I told in the beginning itself we have different types of mycobacterium. Another mycobacterium is Mycobacterium bovis. Okay. This Mycobacterium bovis is nowadays it's not seen much because most of the times, actually all the most of the government have strict criteria in processing the milk. Okay, they have strict criteria in processing the milk. All most of the milks are all pasteurized milk, or all pasteurization is a simple process. They heat cold, they make them to go for certain low temperature. Again, they will heat it. So heat that cooling, so boiling, cooling like that. So they kill the Mycobacterium bovis. So if the mycobacterium, for example, if the person drinks a milk directly from the farm or anything, so if the cow is infected by the mycobacterium, then they will get Mycobacterium bovis in the ileum, in the intestine. So that will create intestinal tuberculosis. Intestinal, okay. Or if the person is having pulmonary tuberculosis and he or she is taking the sputum, swallowing it, you all know swallowing it, and it goes to the intestine and it produces tuberculosis. So mycobacterium tuberculosis can also produce intestinal tuberculosis, understand? Because if the person swallow the sputum, they may get intestinal tuberculosis. So this also can produce intestinal tuberculosis due to what? Swallowing of sputum. Okay. So there are another group of mycobacterium. Mycobacterium avium and atypical mycobacteria. Mycobacteria. They come into the scene, they come into the picture when the person is severely immunocompromised. When the person is severely immuno severely immunocompromised. Okay, so these are the other group of mycobacterium which usually infect a person when he is severely immunocompromised. So they can infect the lung or they can infect any part of the body. Where they enter, they will infect. So there are three types of mycobacterium. At least for your level you should know. One is mycobacterium tuberculosis, which goes and infect the lung primarily. It is pulmonary tuberculosis. There is another group of mycobacterium, it is Mycobacterium bovis, which usually infect the intestine because it comes from the milk, and if you unpasteurize the milk, you will not get this mycobacterium. So if the person swallowing the sputum, then he will get even Mycobacterium tuberculosis infecting the affecting the intestine. And there is another group of mycobacterium like Mycobacterium avium and atypical mycobacterium that will infect when the person is severely immunocompromised. Okay. Now there's a child. Okay, is the first time getting the exposed to the mycobacterium mycobacterium tuberculosis. Okay, when the child is first time exposed to the mycobacterium tuberculosis, is mycobacterium entering the lung, immediately the child will develop a immunity against the mycobacterium tuberculosis. They will try to destroy the mycobacterium and heal that area. Okay, so first time in getting infected, whether it is a child or mostly it happens in the child, it is if the first time tuberculosis enters his body or her body, the baby's body, it is called primary complex. It is called primary complex. Understand? So if the person gets this mycobacterium first time, what it happens is immediately we have what? We have macrophage, and now the mycobacterium is coming. So what they do is they will try to take all this, okay, they engulf it and they will take it. So some authors call it is a endocytosis. Better to call it as a phagocytosis because it is taking some micro. So it is taking it. So this is called phagosome. This is called macrophage. Once it takes the phagosome inside, okay, what next thing they do is they have a lot of lysosomes, right? They have lot of lysosomes which contains enzyme. This is a lysosome. Okay, they contain enzymes. So the immediate role, if anything, they take the bacteria, any bacteria, they will try to fuse the phagosome with the lysosome. What is this? Lysosome. So lysosome has a powerful enzymes to destroy the bacteria. So they have to fuse the phagosome with the lysosome. Normally they do that. But mycobacterium are so powerful, they will not allow them to do this process. They will not allow them to do this process. So mycobacterium are strong bacteria. They will stop the fusion of phagosome with lysosome. Understand? They will stop the fusion of phagosome with lysosomes. Then what they do is they coolly grow within the macrophage. They coolly grow within the because the lysosome is they cannot do anything. Lysosomes cannot do anything. They keep growing within the macrophage. Okay. So then this macrophage enters the circulation. This enters the circulation. Then this you can call it as a mycobacteremia because mycobacterium, but they are within the macrophage, within the phagosome, and they are entering the circulation. So now they are going all over the body, and especially they go to the lymph node, to the, you all know lymph node? Okay. They go to the lymph node. In the lymph node, they, what they will do, because they need some help, they will secrete especially IL-12. They will secrete IL-12. Yeah, these are the macrophage. They secrete IL-12 and immediately, and they have a receptor here. Okay, this also express the some part of the tubercle antigen here, and that also attached to the T cell receptor. This is T cell. Inshallah, when if I'm teaching immunology, I'll talk this process in detail. Now you understand, because otherwise you will not understand the process. So the macrophage releases IL-12. Once it attached to this, they will do this. Okay. So they release the IL-12. This IL-12 will come and activate them. and immediately T cell releases two substances. One is you all know this interferon gamma. Another substance is IL-2 that acts on the T cell itself. Then they will make them to divide into multiple T cells. Understand? So they can secrete more interferon gamma. So they can secrete more. Understand? They can secrete more interferon gamma. Okay. Yeah. See, once again I'm telling the mycobacterium entered and the macrophage takes it and they phagocytose it, and this is called phagosome. Usually if it is other bacteria, they will coolly fuse with the lysosome, they will kill them. Okay, so that's how they manage the bacteria entering the lung. But mycobacterium once enters, they are very clever bacteria, they will stop them fusing into the lysosome. There is a block in the fusion of phagosome with the lysosomes, and the bacteria grows inside the phagosome and they enter the circulation. They enter the circulation. Okay, they enter the circulation. So this all happens within 3 weeks. Okay, so after 3 weeks they go to the within the 3 weeks they will go to the lymph node and they stimulate the, in simple word, they stimulate the T cell to secrete. They get attached to the T cell and two things happen actually. The macrophage also release IL-12 and this IL-12 will stimulate the T cells to produce what? Interferon gamma, and they release another protein called interleukin 2 that will go and stimulate the T cell. It is self-replicating molecule. They will stimulate the T cells to produce more T cells. The IL-2 stimulate the T cells to produce more T cells. Now you got more T cells. Understand? So the IL-12 can come and again stimulate them, right? So they can produce more interferon gamma. They can produce more interferon gamma. Once again I'm telling, once macrophage enters the lymph node, they will attach to a receptor in the T cell, then they will release IL-12. This IL-12 will act on the T cell. The T cell will release interferon gamma. This part we already discussed in the POD many times. Now I'm going to add another molecule, IL-2. Okay, IL-2 is a make the T cells to self-replicate. They will act on the T cell itself. The T cell will divide more and they form more T cell. Understand? This T cell will release more interferon gamma. So in the end, they want to bring more interferon gamma. You understand? So this interferon gamma is very, very important. You all know why. Why it is important? Okay, they will bring more macrophage, and there are other two most important mechanism which is involved in the interferon gamma. This is what? Interferon gamma. So one thing you all know, they will bring lot of monocytes and they will make them into macrophage and they will activate them, right? You all know this, right? They will activate them. And yeah, so this process you all know this, right? How they bring the macrophage, they bring monocytes from the blood circulation, it comes to the tissue, then they become macrophage and they directly activate them. So far we discussed this in the POD. Now the most important function of interferon gamma is not this. The most important function is they make the macrophage to fuse the phagosome and lysosome. They make the macrophage. We have mycobacterium, right? And we have lysosomes. So they stimulate them to fuse. This is the lysosomal enzymes. and they fuse and they will destroy the mycobacterium. Okay, so first thing what they do is they will bring the macrophage and activate them, and the next process is they make the fusion of fusion of phagosome with what? Lysosome. Okay, you understand, this is very important process. Okay, if there is any problem in this process, they cannot kill the mycobacterium, okay. Another most important thing they do is, it is a macrophage, and we have phagosome. Now it is fusing with the lysosome. Okay, this is the lysosomal enzymes, and they need another substance to kill the mycobacterium. The most powerful substance is nitric oxide. You all know nitric oxide? We discussed in the POE, right? They kill directly the microbes. This nitric oxide is needed. So this interferon gamma tell the macrophage to synthesize nitric oxide, so they stimulate a enzyme called nitric oxide synthetase. Okay, they stimulate the enzyme called nitric oxide synthetase. That enzyme will produce more nitric oxide. So now the nitric oxide level is increased. Okay, they all enter the lysosome and they will kill the mycobacterium. So they increase the nitric oxide. Okay, so now you know the three function of interferon gamma. What are they? Anyone. Okay, yeah, tell miss. Yeah. 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 So they increase the nitric oxide, mashallah. So this is a major three function of interferon gamma. Okay, I'm going to little bit introduce some other concept here. See, this macrophage also release TNO. Okay, understand? So this TNF plays a role in recruiting the macrophage. You all understand this meaning? Recruiting the recruiting means bringing the macrophage. Okay, so why I am telling this? This is very important. For example, if there is no interferon gamma, still they can bring the macrophage. Understand? Because of the TNF. See, macrophage releases IL-12. You all know that, right? Now I am going to introduce some other concept here. The macrophage also releases tumor necrosis factor. Okay, this TNF. What's the role of TNF? We know it plays an acute inflammatory role, but it also plays a role in this chronic inflammation. They recruit the monocyte. Okay, actually the recruitment of macrophage is the role of interferon gamma. So far you guys know, right? Now I'm going to tell that process can be done even by the TNF. Okay, so if there is no interferon gamma, still macrophage can release TNF and they can bring the macrophage. Okay, but they can bring the macrophage, but they cannot kill the fusion of phagosomes with the lysosome, and they cannot synthesize the nitric oxide. Understand? So they can bring the macrophage. The macrophage can take all the mycobacterium, but still they grow within the mycobacterium. Understand? See, even they cannot get activated until interferon gamma comes. Activation of macrophage means The macrophage should kill the mycobacterium. Understand? Activation of macrophage means macrophage should have a capacity to kill the mycobacterium. But you understand this? I'm not complicating, it's very simple. See, so far you know macrophage release only IL-12. So now I'm adding the release interferon, the tumor necrosis factor TNF to recruit the monocyte. So interferon gamma also recruit the monocyte. Okay. If interferon gamma is not there, still TNF can recruit the monocytes into macrophage, but they need interferon gamma to kill the mycobacterium. To kill the mycobacterium. Understand? Okay. In HIV patient, T cells are affected, especially CD4 helper T cells are affected. If CD4 helper T cells are affected, what will happen? There is no interferon gamma. What happens? They cannot kill the mycobacterium, but they can still recruit the macrophage. Understand? So the mycobacterium grows very coolly, happily in the macrophage because there is no interferon gamma. They cannot be destroyed. So what happens? This macrophage enters the circulation. They go all parts of the body and they settle there, and mycobacterium keep growing. Understand? So mycobacterium keep growing and the macrophage keep on releasing the IL-12 and TNF. They again recruit macrophage. They take the mycobacterium and they keep on growing. Understand? But they cannot kill the mycobacterium. So in HIV patient, this leads to the dissemination. Dissemination means spreading of mycobacterium to all parts of the body. Understand? So the key molecule is interferon gamma. The key molecule is interferon gamma. You understand or not? Okay. Because this HIV virus infect the CD4 T cell and they destroy the T cell. They destroy the T cell. So the which cell produce interferon gamma? CD4 helper T cell. Understand? So that's why I given a gap here. This is TH cell. Okay. TH cell. TH cell has two subsets, TH1 and TH2. Okay. So please at least you understand it is a T helper. So I don't want to confuse you more. Inshallah in the immunology module we will teach. Okay. CD4 helper cells, they produce interferon gamma. So this interferon gamma is very, very important. Understand? To kill the mycobacterium, it is not important to bring the macrophage. Because if it is not there also, we can bring the macrophage by using the TNF. But to kill the mycobacterium, we need interferon gamma. So that's the reason they spread in HIV patient, they spread all over the body. Yeah. Yeah, of course they are helping them because mycobacterium, if you leave them only in the lung, they'll be affect only the lung. If once they enter the macrophage, they coolly grow within the phagosome and they can go into the different parts of the body. Understand? Because macrophage one stage they keep on growing, right? So they will burst out and the macrophage will liberate it outside. And automatically then the macrophage will be recruited because of the TNF, they will take the macrophage. They will take the mycobacterium and again they grow inside. You understand? So this all leads to the dissemination of the mycobacterium tuberculosis. Okay. Now, now this is a guy who got infected with mycobacterium for his first time. Okay. So when he is infected for the first time, it is called primary complex in the children. Okay. If in generally we call this as a primary tuberculosis. We call it as a primary tuberculosis. Understand? Primary, actually we write like this, otherwise it is primary tuberculosis. Understand? First time if the person gets infected, okay, where it goes to the lung because it is a mycobacterium tuberculosis, it is going to the lung. Okay, this is right, this is left. It is covered by what? Pleura, right? It is covered by pleura. Okay, now taking example also, it entered the left lung. It entered the left lung. Once the mycobacterium enters the left lung, they settle in the distal alveoli, last alveoli of the lower part of the upper lobe. You understand? This is what? Lower part of this is upper lobe, this is lower lobe, and it settles in the lower part of the upper lobe or upper part of the lower lobe. Okay, upper part of the lower lobe near to the pleura. Okay, near to the pleura, so which means in the periphery. Okay, near to the pleura. This is called gone focus. Ghon, gone focus. Immediately this will be taken, the macrophage will go to the hilar lymph node and they stimulate here, and you will get hilar lymphadenopathy. If you see this both together, it is called gone complex. Understand? It is called gone complex. So now they have very good immunity. They are killing the mycobacterium, and after killing they will heal. Okay, when they form a caseating necrosis, right? So if the calcium will deposit and they will become calcified. When they become calcified, okay, when they become calcified, in X-ray it can be seen. If it is calcified in X-ray, we can see. So this is called in X-ray, in radiology, Ranke's complex. Understand? Okay. So when I see in a X-ray Ranke's complex, I will say if he is having primary tuberculosis, or he had primary tuberculosis, it is healed and calcified. Understand? Clear or not? Okay.
So what's the process between the Ranke's complex and Gauss complex?
See, Gauss focus is the lung lesion. If they went to the lymph node, then they will produce the lymph node lesion. Both together called as Gauss complex. Okay, because I told once they enter the lung, after 3 weeks they grow in the macrophage and they will go to the circulation, then they go to the neighboring nearby lymph node. So one of the nearest lymph node is hilar lymph node. So they go there, they stimulate the T cell and they secrete interferon gamma and they will kill the macrobacterium and they produce caseating necrosis, right? So that these two together called as Gauss complex. If there is only lung lesion, it is called gone focus. You got the finding very early. It is gone focus. If both are healed and both are calcified, if you see in the X-ray, it is called Ranke's complex. It is called Ranke's complex. What's your doubt?
Okay, but the person is not sick.
Person is?
The person isn't sick. He doesn't have anything.
Yeah, that's what. They will not develop any symptoms in this. They will not develop any symptom in this. Okay. Primary tuberculosis patient, if they have a very good immunity, they will not develop any symptom. It will be healed and calcified. Understand, whenever, even though they are healed and calcified, that is the dangerous of mycobacterium. All mycobacterium will not be dead. Some will be remain silent and it is inactivated. Okay, they will be very silent. If the person immunity goes down, they get reactivated. They get reactivated. Once they get reactivated, they will again grow. They again grow. Understand? They again grow in different parts of the lung. Okay, they completely grow within the lung. Understand? Okay, or if the person is getting reinfection, okay, reinfection, understand, they usually go to the apex. They usually go to the apex. Okay, why it is going to the apex? Because oxygen is needed for the mycobacteria. Here the oxygen is very good in the apex, so they go to the high oxygen tension is in the apex, they go to the apex. Okay, so they go to the apex and they will involve completely apex of the lung. So this is called secondary tuberculosis. Secondary tuberculosis. Okay, if in a X-ray you are seeing apical lesion, so you should think of secondary tuberculosis. Secondary tuberculosis will produce signs and symptoms. Okay, secondary tuberculosis will produce signs and symptoms because the bacteria is growing, because he is having less immunity. He is having less immunity, the bacteria will produce signs and symptoms. The cardinal symptoms of tuberculosis is they will get cough, sputum. Sputum contains mycobacterium. And they cough and they will take sputum in such a way that they will bring some part of the lung outside. And this will become like a hole. This will become like a hole. This is called cavity. Literally it will become like a hole. It is called cavity. Some part of the lung will come out of the sputum. Okay, so that's how they melt the lung, by making caseous necrosis. So they bring the necrotic areas along with bacteria, mycobacterium. It is very very infective stage. The person can infect the another person. Understand? So what they produce? Cough with sputum. If this bacteria can erode the blood vessel, then they can bring some blood, hemoptysis. They can bring hemoptysis. You all understand? Okay. So when you see a TB patient bringing cough with sputum, and sputum is loaded with mycobacterium, and he is bringing blood tinged sputum, you should think what is happening here. It is eroding the blood vessel. The lesion is very aggressive. Lesion is very aggressive, and they produce other constitutional symptoms like they never feel hungry. In chronic inflammatory process, they don't feel hungry and they don't eat properly. Okay, and they will have on and off fever. They will have on and off fever. Understand? So these are the classical symptoms of tuberculosis. If you see a person with cough with expectoration, and the expectoration shows sputum for AFB, acid fast staining, Zeal-Nielsen staining positive, and he is having night sweats, he sweat night, and temperature on and off, and what, no feeling of hungry, and they don't eat properly, loss of weight. If you add all these stuffs, it is a classic. If you actually, very rarely we get patient like this nowadays, because now everybody, whether they are hungry or not, they are eating good, mashallah. So really I'm telling, nowadays these are classical signs, which means it was there 20 years 30 years back. But nowadays tuberculosis patient, they don't lose weight. I'm telling the reality. They don't lose weight, they don't feel like loss of hunger, mashallah, because the sense of smell and taste overrides them, and they eat. If they cross the albeit, they eat albeit, mashallah. Okay, so what I'm trying to put is just to tell a story, because you will remember forever. In reality, you are not seeing, nowadays we are not seeing this loss of weight, loss of symptom. But cough with expectoration will come, because it is spoiling the lung. It is spoiling the lung, and expectoration will have bacilli. It will have mycobacterium. If it erodes the blood vessel, they will have blood. Okay, so mycobacterium sputum examination is very important at this stage. Sputum examination is very important at this stage. You clear? This is secondary tuberculosis. Okay, this happens when the person immunity is going down, right? If the immunity is so down, okay, then it will enter the blood, and they will spread within the lung. within the lung as a small seed-like deposits. Seed-like deposits. Understand? You clear? So seed is called millary. Seed means millary tuberculosis or tertiary tuberculosis, but it is spreading within the lung. So it is called local millary tuberculosis. Understand? Local millary tuberculosis, or if it goes to the spleen, and it is spreading, or it is going to the liver and it is spreading, or it goes to the brain and it is spreading. This is all systemic miliary tuberculosis. Systemic miliary tuberculosis. This happens when the person immunity is so less. Okay, the person immunity is so less. Okay, sometimes severe diabetic patient may have this problem. A severe renal transplant patient with lifelong steroid therapy, they may have this problem. Understand? Or any long-term steroid intake patient, they may have this problem, or HIV patient may have this problem. Understand? So they spread in the blood and they go to the distant organ and they deposit seed-like deposit. It is called miliary tuberculosis, otherwise called as tertiary tuberculosis. Tertiary tuberculosis. Understand? Any? No, I'm not. I'm not. I'm not getting you. I'm not getting you. Give space and talk.
Oh, so is this only caused by long-term steroid use or something, or can
Yeah.
it be
See.
caused by other reasons
Yeah.
besides
Mainly
long-term
because
steroid use?
long-term steroid use usually produce other infections. Very later stage they will produce tuberculosis infection because first viruses comes in long-term
What
steroid.
about people with will use it for other reasons?
Yeah, for other reasons, inshallah, that's what I'm going to discuss now. Please don't talk. Other reasons, inshallah, we are going to take example as HIV. I will tell what stage what will happen, inshallah. Okay. So now you all understand the primary, secondary, tertiary tuberculosis. Okay, primary tuberculosis, the lesion comes in the lower part of the upper part of the lower lobe, near to the pleura. If the lesion is only in the lung, it is gone focus. If it goes to the lymph node, hilar lymph node, unilateral hilar lymph node, it is lung lesion with unilateral hilar lymph node. For example, left side lung lesion with left side hilar lymph node, it is gone complex. But it is healed, calcified, and I am seeing in the X-ray, then I will think it is a Ranke's complex, which means I'm asking for the example, the person is coming with lung infection, okay, some lung problem, difficulty in breathing problem, he's a smoker, is coming like that. I'm taking the chest X-ray. In the chest X-ray, accidentally I found two calcified spot. I saw the Ranke's complex. So I should be aware that he is already infected with TB. I have to carefully deal with him by giving drugs. I should not suppress his immunity. Understand? These are the benefit you have in seeing the Ranke's complex. Understand? Okay. Now coming, if the person is immunity is down, it gets reactivated or reinfected. When it does that, they need to go. They need more oxygen because they at present they are inactive, right? They need more oxygen. They immediately travel up and they produce apical lesion. When they produce apical lesion, they produce severe caseation necrosis, single lung or both lung, and the person will cough and take the sputum out. They will bring some part of the lung. They produce cavity. Understand? So cavity, apical lesion with or without cavity, it is secondary tuberculosis. Understand? It is secondary tuberculosis. This is a stage that produce symptoms. This is a stage that produce the signs. Then if the immunity is getting so severely low, then they will go to the dissemination and they spread within the lung. It is called local tertiary tuberculosis or local miliary tuberculosis. Or it goes to the systemic circulation and it enters all parts of the organ and it seeds there as a multiple small spots. It is called systemic miliary tuberculosis. Okay. So what we have to do is we have to catch this patient as early as possible at the level of secondary tuberculosis. Understand? So primary tuberculosis, because we cannot catch them because they don't produce any signs and symptoms. Until their immunity is getting low and they are spreading from the primary tuberculosis level, they will produce signs and symptoms. Actually, recently we encountered before 3 years, 4 years back, a female, Muslim female in India from a very poor area, and She got affected primary tuberculosis involving both the lung, full lung. Then we give severe antibiotic, that is anti-tubercular therapy. Then we can able to recover her lung only 50%. Rest of the 50% gone fibrosis. Understand? Then she has to survive with the 50% of the lung. Understand? 50% of the lung means 50% oxygen only she gets. Understand? It's a severe, serious problem. She has lot of children, mashallah. So she has to maintain everything. It's a very difficult problem. Understand? You understand this? So try to catch the disease as early as possible. Otherwise, they will go for fibrosis. Okay, they can go for fibrosis. Okay, but if you catch them early, if you treat them, the whole lung comes back. I mean, it's like a really a gift from Allah Subhanahu wa Taala. That drug is very effective. Drug is very effective. Understand? Because the problem is more usage of this drug, the mycobacterium is getting very clever, and they are giving resistance to those drugs. Okay, inshallah, multi-drug resistant is a really pharmacogenetics concept, inshallah. But you understand certain bacteria, they are resistant to the regular drugs. So we have to give some special drugs. Okay, we have to give some special drugs. Okay, now I'm going to touch a most important thing. Okay, now I feel the person is having tuberculosis. When I can start treating them, how to I confirm the diagnosis of tuberculosis? Remember, I think most of all any other infectious disease, this infectious disease need evidence before treating. Why? These drugs are very dangerous, and like they literally spoil the liver. They literally spoil the liver. Understand? So this before giving the drugs, okay. For example, there is a we call dyes into two group who keep on speaking, take dars, all those stuffs, and those who work in the field, go to the people work in the field. So such a dai was working in a TB prone area. Actually, he got infected. He is having severe cough, expectoration, and what to say, hemoptysis, all those stuffs. But sputum was negative. Sputum was negative. We did all the investigation, all the negative for tuberculosis, but he is having keep on having this symptom. So what we did is we discussed with the pulmonologist. Okay, so pulmonologist said that why we can't try with ATT. Let's see the response. Anti-tubercular. Let's try with anti-tubercular therapy. Let's see the response. Then I discussed with his name is Fayaz, and I told him like this is a real story. I'm not just making the story. So then we convinced him to take the drug. Actually, after a week, he told, brother, I don't want to take any try of this drug. Inshallah, Allah will cure me because this is making me to suffer more than that. So because it creates lot of peripheral neuritis, if you touch the person, you will feel severe pain, and they will have lot of liver toxicity. Okay, so then we stopped him. Alhamdulillah, within 3 months he recovered. Maybe due to the unknown infectious agent producing this. Okay, so that's why it is very much necessity to know 100% the person is affected by the tuberculosis. So this is the very important part among all the things. Okay, so first of all, clinical signs. Remember, all the lung disease we have to interpret with three findings: clinical signs and symptoms, pathological investigation reports, all investigation reports, and radiological findings. Correlate these three and come to a diagnosis. Radiological reports. Okay, so these are the three things is needed to come to a very difficult pulmonary diseases. Okay, to diagnose the pulmonary diseases. Okay, so first thing is you all know the five classical signs and symptoms. Nowadays the patient is not coming with these five classical signs. So we do the laboratory investigation. First thing is we take the sputum. Easiest thing. Take the sputum, give it to the microbiology to check for acid fast baseline. They do simple staining, Zeal-Nelson staining. If it is positive, they will tell it is positive. Okay, if it is negative, your luck, that sputum is not having a mycobacterium. So it will come as a negative, right? Then another method is take a lesion, do a bronchoscopy, take directly from the lesion and give it to the microbiology. In the tissue also pathology we put Zeal-Nelson staining. That's a technique. And we see if the bacilli is there, alhamdulillah we can start the ATT. Again the bacilli is not coming. That area there is no bacilli. Understand? We are not taking the whole area, right? That area there is no bacilli. Then what we do is we'll we'll take another spot of tissue, okay, then we give to the culture. The problem is in the culture it takes 10 to 12 weeks to give the to see the report. 12 weeks we cannot wait, okay, especially 12 weeks means approximately 3 months, okay. Now alhamdulillah, you all know LJ medium, Lowenstein Jensen medium, okay, that is the medium for tuberculosis, okay. Then alhamdulillah, now we have very good liquid media. It is some electrified technique they do, they give the results in 2 weeks, okay. But 2 weeks also late, yani, understand, 2 weeks is not like very short. Then we have a very special technique called polymerase chain reaction, PCR. Even one bacilli they will detect it, even one bacilli they will detect it. But even though polymerase chain reaction is so helpful, but still we rely on gold standard method is culture. We wait for 2 weeks, okay. We try to give some symptomatic relief and we wait for 2 weeks, okay. And the culture report will come. If it is definitely of tuberculosis, then we start with anti-tubercular therapy, okay. Now the question is, it is also negative, okay. The technique here is this kind of cases only we will handle in real time. That is also negative. Now the question is whether I am dealing with the chronic granulomatous diseases like sarcoidosis or tuberculosis, okay. So then there is no other go, try ATT with the consent of the patient, explain to the family, try ATT for 2 weeks. It will definitely show the response if there is a ATT, if there is a tuberculosis, you understand. Otherwise it is a sarcoidosis, otherwise it is a sarcoidosis, okay. You all understand this? So now I'm going to talk about if in a HIV patient what will happen. Oh, sorry. Okay, that's a, I will stop here. Inshallah, we have the class afternoon.
Doctor,
Mhm.
so I have a question. Like my mom, a year ago, she had like a TB in the lymph node, and they did the investigation. All thing is positive except the sputum. So I think if we have non-lung TB, it's gonna give us all the result is positive except the sputum. In this case, should we give the anti?
See, for example, if the person is having definite tuberculosis bacilli in the lymph node, okay, and she is not producing any signs and symptoms,
No, they did the exam for the TB, that one for the TB, 10
mandatory test.
millimeter, and it was like more than 10 milliliter, and they give her the drug for, yeah, and that you said it's damaged the liver, and they give her with this drug like vitamin B to prevent the liver. But my question is say like I have to be sure. In this case, like we
Yeah,
need
it
to.
is a 100% tuberculosis case, and they did a correct treatment because they gave the drug.
Yeah, they give the
And
drug.
how long she was taking the drug? 6 months.
6 months. Yeah.
So after 6 months, you can bring back the liver. Liver is a very good organ. They will come back, and it will take 1 year time. And so only thing is, it's a cure. She if she
Yeah,
had
yeah,
finished her 6 months, definitely it would have
my
been cured,
question, I got
inshallah.
confused because you said that we have to make sure because of the symptoms. In my mother case, there was a lot of symptoms, and in other hand, there was no symptoms. Like they took time. It is TB.
Yeah, that's the problem in tuberculosis.
Yeah,
Some patient will produce symptoms, some patient will not produce symptoms. Some patient will produce symptom, but investigation shows negative result. In your mother case, alhamdulillah, it is everything crystal clear.
yeah.
She had a symptom, and the lung is not showing the lesion, but lymph node show the lesion, and even the lymph node it shows. We don't bother if there is any evidence of bacilli in the body in any organ, we will immediately treat with ATT. The treatment varies whether it is a secondary or it is a
And the
tertiary.
problem that my mom is a smoker. Like she had been smoking before
Yeah, that's why
40 years now.
this is a big problem. Actually, the thing is that uh, the problem is the lung is already affected by the infection, and if she is already smoking, that will inhibit in the inflammatory response. What these drugs does is they kill the mycobacterium, and it has to be removed by a good inflammation. And what happens in the smokers, the inflammation is suppressed, okay, and they have increased free radical. That is not good for healing. the for the healing process. Okay, what you advise her is
And she has a diabetes, and she's also diabetic person.
okay. You are slow by may Allah make her things easy. You are a little bit adding more and more stuff like see. Uh, Tell her to avoid smoking, not the sake of her health. Tell her to avoid smoking for the sake of Allah subhanahu wa
Doctor
ta'ala.
wants
So
them to
that is
focus.
very important. First of all, please listen, Yani. Like until we leave, we cannot leave the smoking just because thinking my health will come. This is all. Like I feel like because that's why even in states they bring church into the picture to quit smoking. Okay, so spiritual way of living smoking is a success. Many studies said that. So drive her towards the spirituality. She has to stop smoking because female smoking they get lung cancer fast. Understand? We don't know why it is. So already she had a tuberculosis infection and diabetic. Her immunity will be less. Maybe she got tuberculosis because of her diabetic. I don't know.
Doctor, once you have to tell us the ciliate in the trachea will remove because of the smoker.